Okay, good morning, ladies and gentlemen, and thank you very much for giving me the opportunity to participate in your prestigious meeting. And I would like to say that I'm honored, John, to be here. And I attended a lot of courses with your father, Donald Doughty, in Salt Lake City, and I think they were very useful for me to stand up here today. And I'm sorry, I prepared the debate, and I thought you were going to debate something, but I think you came off with a nice conclusion that you are not performing off-pump. You reviewed most of the retrospective data that support off-pump in some subgroups, and then you compared off-pump to drug-eluted stents. So I think you were fair. And I thank Dr. Ghazala for pointing out the importance of the completeness of revascularization. And basically, as we know, that this has been a controversy over the year in cardiac surgery, off-pump, on-pump, and has been studied thoroughly and looked at thoroughly. On-pump CABG has been effective, safe, and time-proven technique, and it is the gold standard that is comparing to all sort of revascularization, especially when it's completed. On-pump CABG, yes, has its own worries about myocardial ischemia, neurocognitive dysfunction, stroke, and activation of inflammatory pathways, and so on. We were all hoping that off-pump surgery would be the promising alternative technique. And I should say that at one point of my career, I was performing almost 85% of my practice was off-pump. But then we looked at the literature, and basically I'm going to review one of the biggest retrospective trial is the New York Registry trial, where they had 9,000 off-pump patients looked at. And basically, as we see, the off-pump patient has significantly higher incidence of gastrointestinal complication, but there was no difference in the 30-day in-hospital risk-adjusted mortality. There was no risk, there is no difference in myocardial infarction, or wound infection, or renal failure needing dialysis, or respiratory failure in this group. Again, the short outcome, there was a higher incidence of stroke in the on-pump patient, and there was a higher incidence of bleeding, and there was a longer hospital stay by 1 day for the on-pump patient. But then if we look at the three-year follow-up of this registry, the on-pump CABG patient had a higher survival, and the on-pump patient had less need for revascularization, which was both statistically significant. And I think that is really the stake of the matter, is the patient's survival and the need of revascularization. Otherwise, we can just stent the patients. This is another retrospective analysis, and again, they come out with the same conclusion that there was no difference in the mortality or other incidence of stroke and MI, and basically we can say that the off-pump patient received less grafts and less completeness of revascularization, and the completeness of revascularization was defined by the planned graft before surgery according to the number of the diseased vessel. And again, this was another retrospective review published in the circulation in 2010, and basically shows that the long-term results were better with on-pump patient. Off-pump patient had a significantly lower risk of atrial fibrillation and blood transfusion. But again, the incomplete revascularization was much higher in the off-pump group. And so basically, that was the retrospective, the biggest retrospective trial. And if we look at the randomized control trial, there were a few small randomized control trials that were criticized because they lacked power, the number of patients was small, was a single center. Until we get the three big randomized trial. One was the Ruby trial, where they enrolled 2,200 patients in 18 centers, and they had 53 attending physicians, and they did a follow-up angiogram in 1,371 patients. And basically, all patients who were urgent or elective CABG were included in this trial, and excluded emergencies and patients with porcine aorta or very poor target vessels. And basically their primary report short-term outcome was death and major adverse event, and there was no difference. And there was a difference in the off-pump showing less graft or incomplete revascularization post-op. The primary endpoint from 30 days to 1 year showed that the cardiac-related mortality was higher with the off-pump group, and the non-fatal MIs were higher with the off-pump group, and major adverse events were significantly higher in the off-pump group. And we can see this Kaplan-Meier curve here showing the difference in mortality between the off-pump and on-pump group at the long-term endpoint. Secondary endpoint, again, the off-pump group showed incomplete revascularization. The graft patency was significantly lower in the off-pump group with a significant p-value, and there was no difference in the neurocognitive testing. So basically, there is no point of there is no benefit of the off-pump group, either long-term or short-term, except for the blood transfusion and the atrial fibrillation complication. And if you look also at the quality of the targets, we see that the quality of the targets and the quality of the anastomosis were worse in the off-pump group comparing to the on-pump group. And those are all the neurocognitive testing showing that there was no difference between the two groups in different neurocognitive testing modalities. So the result did not differ when surgery was performed by residents or attending physician, or in a high or low volume center, and that was a conclusion of the Ruby trial. The conversion rate was a bit higher in the Ruby trial, but the reason that they pointed out was that the patients were not selected, was a randomized control trial, and they had to do difficult patient who might be excluded in real life. And basically they concluded that this trial did not show any overall advantage of using off-pump as compared to on-pump group, and there was a consistent trend toward the better outcome in patient undergoing conventional pump, as we've seen in the literature. This was another randomized control trial showing that after 3 months there was significant decrease in the overall graft patency in the off-pump patients with a significant p-value. And again, the myocardial ischemia and myocardial injury, this was a randomized control looking at the RV function, comparing on-pump and off-pump, and basically there was no difference between on-pump and off-pump after 3 months for those patients. I'll skip this. We'll come to the coronary trial, and this was a big trial after the Ruby trial, and this was a prospective randomized control trial where they involved 4,752 patients in 79 centers in 19 countries. And basically in the corona trial, the primary hypothesis was that off-pump CABG would reduce the rate of major clinical event in the short outcome, and would have a consistent benefit with the long term, which is 5 years. So their outcome was a composite of rate of death, non-fatal cerebrovascular accident, and non-fatal MI, and a new renal failure requiring dialysis within 30 days. And the second one, the second outcome, they were looking at the same composite plus need for repeat revascularization with a mean of 5 years. And the third endpoint was looking at the quality of life of those patients. And basically, in conclusion of the result, they say that there was no difference in the primary outcome between the two groups, off-pump and on-pump, and we see the p-value. And there was, there was a difference in the need for repeat revascularization in the off-pump group comparing to the on-pump group, and that was also statistically significant. And there was no difference in the quality of life scoring or the neurocognitive dysfunction. So this was a second big randomized control trial. And again, in their result, they showed that there was fewer grafts were performed in the off-pump group than in the on-pump group, and there was incomplete revascularization by definition. Again, the coronary trial there was a small difference, even though there was a small difference in the neurocognitive function earlier, but this difference has disappeared at the 1-year follow-up. And they concluded that there was no significant difference between off-pump and on-pump with respect to the 30 days death, myocardial infarction, and renal failure. And if we look at the two trials, there was a difference because the Ruby trial was criticized because surgery was performed by trainees and inexperienced surgeon and so on. So this trial involved only surgeon who had 2 years experience and who had performed more than 100 off-pump patient. There was twice the number of the participants, so the number of the coronary trial patients were double the number of the Ruby trial patient, and trainees were not involved in this study. And their crossover was less, was 7.9% in coronary trial, and this might reflect the experience of the surgeons in the coronary trial. And basically, even despite the improvement in the technique and the stabilizers and so on, off-pump did not show any benefit comparing to on-pump. The SMART trial, which is also a very important trial because was led by one of the most famous off-pump surgeon, Dr. Pascas, and even though he could not show any benefit in the long term and in the graft patency in this randomized control trial where they followed up the patient for 7.5 years. And this is also another recent publication where, again, they did not show any benefit in the long term of off-pump comparing to on-pump. And if you look at the meta-analysis, there is a huge number of meta-analysis, but just reviewing the meta-analysis of the randomized control trial, again, long-term follow-up showed repeated intervention and incidence of death was significantly lower in the on-pump group as shown before. So I think we just should stop just following the same routine and the same trend, and I'll finish my presentation in the debate.